Hello and welcome everyone. I'm Jessica Collins, the Executive Director of the Public Health Institute of Western Mass, and we are so very glad that you are all joining us right now as people come in to the webinar. Very glad to have so many of you here for this important information regarding healthcare coverage in Massachusetts and some regional Western Mass data. There was a tremendous response to this webinar, and again, just incredibly grateful to the vast audience and the different sectors that will be joining us today. I do have some quick housekeeping that I want to share with you. We will be recording this webinar. It's recording right now. Click Show Captions to enable automatically generated closed captioning. To submit a question, use the Q&A feature found in your Zoom menu. Panelists will write a response as they are able. And if we're not able to answer it today, we will do our best to look into the question. And next week, when we send out the package of the recording and the slides and the responses, we'll do our best to answer every question. We won't, in this 60 minutes, have a live Q&A, so we really encourage you to write your questions in the Q&A feature. Like I said, the recording and materials will be emailed to registrants next week and posted on our website. And if you encounter technical issues, please message the host and we will do our best to assist you in resolving them. And before you sign off, we would love for you to take our survey at the end. We felt a regional presentation was critical to have about this topic, since we know there are so many folks in our 4 counties whose lives are being impacted and will continue to be impacted by federal health policy changes. It is critical that we disseminate information and resources across Western Mass to support our thousands of family, neighbors, and community members. I am so grateful to the Blue Cross Blue Shield of Massachusetts Foundation team, Katherine Howitt, Jesse Gottsegen, and Caitlin Kenny Walsh for all of the work they have been doing for years, but in particular, more currently, the work they're doing with the Commonwealth leaders to break down the impacts of federal health policy on Massachusetts in a straightforward way. I am also grateful that they are convening ongoing conversations to strategize for our future. I want to thank also my colleagues, Lisa Rangeli and Sinead Coe, for quickly putting the regional mass health data together in a format that can be shared today. And also to Ilana Steinhauer, Executive Director of Volunteers in Medicine Berkshire, who's also a PHIWM board member, who will be sharing more currently what VIM is doing and what's happening here to address these healthcare challenges. So at this point, I'd like to turn it over to Katherine Howitt, Vice President of Policy and Research, and Jesse Gottsegen, Senior Policy and Research Analyst from the Blue Cross Blue Shield of Massachusetts Foundation, who will be starting us off today with their presentation. Thank you.
Great. Thank you so much, Jessica. And thank you to you and to your whole team for organizing today's webinar. I know Jesse, I speak for Jesse when I say we're thrilled to be here and to be speaking with all of you on this really important topic. We wish it were slightly more uplifting, but we're glad to be here nonetheless. As Jessica said, my name is Katherine Howitt, and I'm the Vice President of Policy and Research at the Blue Cross Blue Shield of Massachusetts Foundation. And just to give you a sense of how Jesse and I will be structuring our presentation today, I'm going to start off by briefly introducing the Blue Cross Blue Shield of Massachusetts Foundation to you. From there, I'm going to turn it over to Jesse, who is going to provide some high-level context and background on the key public health insurance programs in Massachusetts, Mass Health and the Health Connector, since these are the programs that are most directly impacted by the One Big Beautiful Bill Act, or OB3, as we have been referring to it. From there, Jesse and I will walk through some of the key healthcare provisions in OB3, and then we will wrap up by reviewing what we know about the potential impacts of these provisions on healthcare and healthcare coverage in Massachusetts. Before I do my blurb about the foundation, I also am gonna give you this caveat that you will hear us repeat a few times throughout this webinar because it's really important that the content that we're reviewing today it's based on the information that is available at this time. And we are still waiting for guidance from the federal government about how they want to see many of these provisions implemented. So some of this is subject to change based on that future guidance. I also just want to note that I know Jessica mentioned, please throw your questions into the Q&A. We look forward to answering as many of them as possible. I did want to note that we are not going to be able to answer questions about what these changes will mean for individual cases or individual members. So if you're coming to this webinar with questions about what will this mean for a specific person in your life or in your work, we're going to throw some resources into the chat that are great places to go with member-specific questions. So with that, I just want to give you a brief introduction to who we are at the Foundation. We are a nonprofit organization founded in 2001. We are separate from the Blue Cross Blue Shield of Massachusetts, the insurance company, and we have our own board of directors. The mission of our foundation is to ensure equitable access to healthcare for everyone in the Commonwealth who is economically, racially, culturally, or socially marginalized. And we work to advance this mission both through community partnerships or grant making, through policy and research work, and also through convenings. And we focus our work in three main focus areas: care and coverage, behavioral health, and structural racism and racial inequities in health. Okay, with that as a bit of a background on the foundation, I'm now going to turn it over to my colleague, Jessie Gottsegen, who, as I mentioned, is going to start us off by just providing some background on Mass Health and the Health Connector as they are structured today, so that we can then talk about how they will be changing under OB3.
Great. Thank you, Catherine, and good morning, everyone. It's nice to be here with you all. As Catherine mentioned, we're going to start by taking a step back and first reviewing Medicaid in Massachusetts. So, as you may know, in Massachusetts, we refer to the Medicaid and Children's Health Insurance Program as a single program called Mass Health. The Mass Health program covers almost 2 million people, so that's more than 1 in 4 Massachusetts residents. And that includes many children, people living with disabilities, and adults 65 and older. And I'll say a bit more actually about the geographic distribution of those enrolled in the program on the next slide. But first, just in terms of how people qualify for Mass Health, it's based primarily on their income. So most adults under the age of 65 can be covered if their annual household income is below 138% of the poverty level, which amounts to a little under $22,000 for an individual. Adults over age 65, many of whom also have Medicare coverage, typically have a slightly lower income cutoff, and they're also subject to asset limits. And then there are other groups, such as children under age 19, pregnant people, and people with disabilities who have higher income cutoffs to qualify. So these are, the data and numbers that I just touched on are important to understanding the Mass Health program, but we also find it's really critical to remind ourselves that these numbers also represent real people. And we think it's important, hearing more about their stories reminds us just how important the program is. And so with that, we wanted to just briefly share 2 short stories of people who are on or who had been on Mass Health. And these stories were featured in actually in a 2025 Foundation report. Okay, so the first story we just wanted to share is about the family pictured here on this slide. So this is a woman who lives outside of Boston with her son. Her son has severe autism and many other complex healthcare needs. The mother was working as a school bus driver, but had to eventually leave her job to care for her son full time when his condition caused him to become increasingly aggressive and he could no longer attend school. Luckily, both mom and son are covered by Mass Health, so not only is he able to get, the clinical and support services that he needs, in order to continue living in the community, but his mother is also able to get the services that she needs to keep herself healthy enough to also stay as his primary caregiver. So that's one story, and on the other hand, there are people who use Mass Health only very briefly. So we also spoke to a woman who had returned to Massachusetts after living out of state. However, upon returning, she faced some really big challenges. So she was unemployed, didn't have health insurance, and she was dealing with some really painful dental issues. Fortunately, she was eligible for and was able to enroll in Mass Health. So she was able to get treatment for the dental issue before it worsened and grew into an even more painful and even more expensive problem. Eventually, she was lucky enough to find a full-time job that did offer her health insurance, and that meant that she was able to drop her Mass Health coverage. So her story shows, how Mass Health can really step in and serve as a safety net during unexpected times or transitions in people's lives. However, what you'll see a little later on is that some of the Medicaid eligibility changes that are coming as a result of OB3 may make it harder for people in situations like this one that I just described to both get Mass Health coverage and maintain their Mass Health coverage. So again, I think both of these stories they highlight really the critical role that Mass Health plays in both making health insurance coverage possible for people who either would not otherwise have it, either because their employer does not offer it, or because they can't afford to pay for it themselves. So in that way, Mass Health brings its members, not just access to healthcare and better health outcomes, but it also really brings protection from what we know are the real financial burdens of medical debt. Okay, so that is a brief overview of the Mass Health coverage landscape. I'm now briefly just going to circle back to some of that Mass Health enrollment data to really help give us a better sense of how enrollment in the program varies by county. So I think it's worth noting here there is really some stark variation in Mass Health enrollment rates across counties in Western Massachusetts specifically. In fact, the counties with both the lowest and the highest enrollment rates of any county in the state are actually both located in Western Massachusetts, with Hampshire County, which is shaded in that very light purple blue, having an enrollment rate of just 18%, while 42%, or nearly half of residents in Hampden County, are enrolled in the program. So what drives differences in enrollment by county? It's driven by a range of factors, including things like poverty rates and other demographic characteristics. It is worth noting that Hampden rate, which again has the highest enrollment rate of any county in the state, has the lowest median household income of any county in the state. Okay, so turning to the next slide, we're now going to shift a bit from Mass Health coverage to a quick review of Mass Health spending and federal revenue. So when it comes to Mass Health financing, the first really important thing to know is that Massachusetts does not fund Mass Health on its own. The program is jointly financed by the state and federal governments. So the federal share of costs is preset according to a very specific formula, which is often referred to as the match rate. And that is a set formula for particular populations or services. So most of the Medicaid portion of Mass Health expenditures for services are reimbursed at a federal matching rate of 50%. So what that means is that for every dollar of Mass Health spending, the federal government typically reimburses the state 50 cents. However, there are some Mass Health expenditures that actually qualify for an even higher matching rate. So for example, the population that became eligible for Mass Health as a result of the Affordable Care Act's Medicaid expansion, for that population, the federal government contributes 90% of the program spending. And it's worth noting here that, many of OB3's eligibility cuts that we're going to talk about shortly, many of those cuts actually target this specific population, the expansion population, which again is primarily paid for by the federal government. As you can see from the chart here, this shared federal state financing means that Mass Health is a huge source of federal revenue that helps support Massachusetts state budget overall. So for example, in state fiscal year 2025, federal Medicaid funds to the state totaled $12.3 billion, which accounts for almost 90% of the total revenues that came into the state's budget that year. Really having an understanding of this shared state federal financing structure, it's really important, especially when we think about OB3 and its impact on federal revenue to the state, which we're going to dive into a bit later on. But for now, we just really wanted to make sure everyone had this sort of background understanding of the federal state shared financing structure. Okay, so turning now to the next slide, we're now going to shift from this brief overview of Mass Health to a focus quickly on a review of the Health Connector, which, like Mass Health, is a really critical piece of the state's coverage landscape. So the Health Connector or Connector is Massachusetts' state-based marketplace. The connector offers health and dental coverage for both individuals, for families, and for small businesses in Massachusetts. But what we're going to focus on here is the health insurance coverage it provides to more than 350,000 individuals and families in the state. So there are two primary coverage options that are sort of featured on this pie chart, and these are the two coverage options that are available to people through the Health Connector. So the first, connector care coverage, is typically available to people who earn too much to qualify for Mass Health, but who can't afford to purchase coverage on their own. So this includes individuals with income up to 400% of the federal poverty level, which is roughly around $63,000 annually for an individual. There are currently more than 280,000 people who get subsidized coverage through connector care. And the program leverages what are known as the advanced premium tax credits that were first established as part of the ACA. So that's connector care. The second option, which is shown in the purple piece of this pie chart, the second option is unsubsidized coverage. And there are currently around 69,000 people enrolled in unsubsidized coverage through the connector. Okay, so now that we've sort of gotten situated in the public, sort of the current public coverage landscape, we're now going to go to the next slide where I'm going to talk through some of the key Medicaid provisions in OB3. So OB3 passed as part of the budget reconciliation process back in July of 2025, so almost a year ago now. And the law is massive in scope, and it does a number of things, including preserving and expanding some tax breaks and increasing spending on things like border security, defense, and energy. The law also introduces several healthcare provisions that will reduce federal spending on Medicaid and marketplace coverage. So the Congressional Budget Office, or the CBO, estimates that the law will reduce gross federal Medicaid and CHIP spending by nearly $1 trillion over the next 10 years. And, as I mentioned, the law is massive in scope. And what we're going to focus on today, we're really going to focus in on the key provisions that take aim at Medicaid and marketplace coverage and really threaten to drive up, as a result, the number of people without coverage in the state. And to kind of help keep us organized, we're going to categorize these different provisions into three big buckets. So the first bucket we're going to focus in on is Medicaid eligibility restrictions. And these are the provisions that will both make it harder to qualify for Medicaid and also make it harder for people who do not qualify who do qualify, to stay enrolled. So that's the first bucket. The second bucket is the provisions that really lead to changes to Medicaid financing. So this bucket includes restrictions that will make it harder for states like Massachusetts to generate their share of Medicaid costs. And then our third bucket, which Catherine's going to walk us through, these are the provisions that create restrictions to eligibility for subsidized coverage through the marketplace, or Health Connector as it's known here in Massachusetts. I will note at the outset that all of these changes are not hitting immediately. Most of the eligibility cuts trickle in over the next 2 years, so between 2026 and 2027. And then most of the financing cuts really don't start until towards the end of 2027 and then get deeper over time. So with that, let's start by focusing in on two of the key provisions within the Medicaid eligibility bucket. These are sort of the key position, like really the two of the provisions that are really going to potentially drive up coverage loss in Massachusetts, and that is work requirements and more frequent renewals or 6-month redeterminations. Together, these provisions will really have, again, a compounding effect on coverage through Mass Health, making it harder for people both to get coverage and for people to stay enrolled once they have coverage. These requirements generally apply to what is often referred to as the state's expansion population, which I mentioned earlier. That in Massachusetts, the expansion population primarily refers to adults under the age of 65 who do not have dependent children and who are not enrolled in Medicaid on the basis of disability or pregnancy. I'll note that, as Katherine mentioned earlier, the state is still awaiting some additional guidance from CMS to really be able to fully pin down the specific populations affected by work requirements and 6-month redeterminations. However, based on the state's initial analysis, they've estimated that up to 360,000 members will need to either comply with or apply for an exemption from work requirements and or will experience more frequent renewals. And I will flag here that once I've walked through a bit more detail on these two new eligibility rules, I'm actually going to turn it over to Lisa Rangeli of the Public Health Institute of Western Mass, who will share with us some of the analysis that they've conducted about the geographic distribution of those expected to be impacted by these new requirements. And she'll really focus in on where these members live across Western Massachusetts specifically. So before I turn it to Lisa, let me first get into a bit more detail about these new requirements. So starting with work requirements, these new requirements will mean that to enroll in and keep coverage, adults that this applies to will have to demonstrate that they're either working, in school, or volunteering, or a combination of these activities for at least 80 hours per month in order to stay eligible for Mass Health. Affected members can also meet the work requirement by earning at least $580 per month, which is equivalent to 80 hours of work based on the federal minimum wage. However, this is really worth highlighting in a state like Massachusetts because we have a higher minimum wage. So what that means is we expect that members will be able to meet the earning requirement here in Massachusetts by working more like 35 to 40 hours a month. So if someone can demonstrate that their monthly income is $580 or more, they will meet that income threshold requirement, even if they are working less than the 80 hours a month. The law, as I mentioned earlier, does spell out a number of categories of people in the expansion population who could apply for an exemption from this requirement. This includes, for example, individuals who are pregnant, individuals who participate in a substance use or rehab program, or individuals who meet the definition of medical frailty. So, we know that over 3/4 of non-elderly Mass Health members are already in working families, and those who aren't are often in school or taking care of a child or a family member with a disability. So, what this means is we know that many members are already meeting these requirements or should qualify for an exemption. However, many of these members will lose coverage not because they don't meet the requirements, but because of the added paperwork and the administrative burden that this new requirement creates. For example, people might not receive or understand the notices they receive, or they won't have the right paperwork to prove their work or their exemption. And, this is exactly what happened in Arkansas, where they implemented work requirements in Medicaid briefly in 2018. So studies from that state showed that the vast majority of those who were targeted by the requirement already were working or already qualified for an exemption. However, these requirements resulted in significant losses in Medicaid coverage, significant increases in the percent of uninsured adults in the state, and really no significant changes in employment rates. So now shifting a bit to the other key new eligibility rule, which is 6-month redeterminations or more frequent renewals. So currently, Mass Health redetermines its members' eligibility every 12 months. However, under OB3, states will now be required to redetermine Medicaid eligibility every 6 months for certain adults. And while this largely applies to the same population as work requirements, it's important to note that it doesn't have as many exemptions. So some people who may be exempt from work requirements will still have to redetermine their eligibility more frequently. And again, we know, like work requirements, we know that people often lose coverage during redeterminations, not because they aren't eligible, but because they don't meet certain, cumbersome paperwork or documentation requirements to show they are eligible. So now that we've reviewed those eligibility changes, I'm going to turn it over to Lisa to walk us through some of the analysis that their organization has done to really help give us a better sense of where those likely impacted by these requirements live. So, Lisa.
Thank you so much, Jesse. Good morning, everyone. I appreciate the opportunity to share some data with you. I really want to give a shout out to Blue Cross Blue Shield of Massachusetts Foundation for being able to secure more localized data from the state. This is our first kind of sneak preview of the potential impacts since the bill was passed. And also, again, shout out to Sinead Keogh on our team for creating the maps and charts and helping make sense of the data. This is a preliminary analysis, so I'm going to share 3 slides, and just keep in mind, this is based on Mass Health projected expected impact among expected enrollees, and we've used census population estimates for some of the population-wide impacts, but it does get us in the ballpark of how Western Mass communities will be impacted. So this first map is looking at the numbers. So when you see each county, you see a number. So for example, Hampden County says more than 30,000, close to 31,000 Mass Health enrollees will be impacted by the work requirements. As Jesse was explaining, they may well likely also be affected by these 6-month redetermination requirements. So comparing to the population of each county overall, we see in this map that Hampden County is the second most impacted county, or it might even be the first, but it's one of the top 2 most impacted counties. And actually, when you look at Berkshire and Franklin counties to the left and to the top of the map there, you see that 3 of the 4 most impacted counties in the whole state, when you look at total population, are in Western Massachusetts. So that's very important to know. When we look at, and overall across all of Western Massachusetts, the total is about 47,000 people expected to be impacted. When we look at the next slide, we are looking at, so you can advance to the next slide. Thank you. So when we look at the next slide, we can see a little bit different way of looking at the data. So this is, again, the same numbers, but we are using the overall number of Mass Health enrollees, so people insured with Mass Health. So when we look at the numbers this way, we see that some of the more rural counties, counties with smaller populations, actually have a greater proportion of Mass enrollees who will be impacted. So that's something important for providers to know in those counties. So for example, in Hampshire and Franklin counties, we see upwards of 20%. So 1 in 5 Mass Health enrollees are expected to be impacted by these work requirements. So it's going to be very important to work with those enrollees around that, as well as the 6-month redeterminations. We also have zip code level data that gives even more granularity to these proportions. And when we look at that, we see pockets, for example, in southern Berkshire County, where there's a higher percentage of enrollees who will be affected. And then my final slide looks at the top 10 cities by numbers in Western Mass. So Springfield, you see roughly 15,000 folks are going to be impacted. And that's about almost 10% of the total population of that city. So we see cities in all of our counties. So Springfield, Chicopee, Holyoke, and Westfield and West Springfield, Agawam. So we see big representation of impact in Camden County, but we also see Greenfield in Franklin County being affected, and then Pittsfield and North Adams in Berkshire County, and then Northampton in Hampshire County. So in all 4 counties, we see the impact in our city, in major cities in those counties, in terms of the total population of those cities and what percentage will be impacted, as well as the numbers. So this is definitely of grave concern for our region, and we're really grateful to be able to give you at least preliminary data on what the impact will be. And now I'm going to turn it back over to Jessie and Katherine.
Great. Thank you, Lisa, for walking us through that, that really important additional data. I'm now going to shift us back to reviewing some of the other key healthcare provisions in OB3. So what we're going to start with here is a third area of cuts under that Medicaid eligibility bucket, that first bucket that we wanted to review with you today. So this under OB3, there's a provision that scales back the categories of legally present immigrants that will be able to qualify for Medicaid. This means that many groups of legally residing immigrants who actually currently are eligible for Medicaid, including refugees, individuals granted asylum, they will no longer be eligible. The list of immigration statuses on the right-hand side of the slide are the ones who will be losing Medicaid eligibility under OB3. Estimates from the state suggest that this impacts roughly 2,500 people who are currently receiving their coverage through Mass Health. And when this change goes into effect in October of this year, many of them will lose their Mass Health coverage. So now let's turn to that second bucket of healthcare cuts in OB3 on the next slide. And these are the Medicaid financing cuts. So as I mentioned earlier, Medicaid is financed by the state and federal governments, with states paying about half the cost of the program. The law, OB3, reduces federal spending in Medicaid, not only through cuts to Medicaid eligibility, which we just walked through on the last few slides, but also by making it harder for states to raise their share of Medicaid spending. So there are a few different ways that the law does this, but since they're all pretty technical, I'm going to focus today on the cuts to provider taxes, just to give you a sense of what is driving some of these cuts. So what are provider taxes? Provider taxes are an established tool that are used by all but one state to finance their Medicaid program. These are assessments on certain entities like hospitals, nursing homes, and ambulances, and the revenue from these taxes helps states pay for their share of Medicaid spending. So in Massachusetts, provider taxes were projected to generate $2.3 billion in state fiscal year 2025. And when spent on Medicaid, these revenues draw down a federal match, which is also then reinvested by Mass Health into the broader healthcare system. OB3 places some new restrictions on how states can use provider taxes to raise their share of Medicaid costs, which is expected to result in a significant drop in the federal revenue that's coming in to support our Medicaid program in Massachusetts. So this means that Massachusetts, like many other states, will have to make up this lost revenue out of, for example, out of general funds or by making cuts to its Medicaid spending. There is another provision that will reduce federal Medicaid funding flowing into states, including to Massachusetts, and that's state-directed payments. But given some time restrictions today, I'm not going to dive into that into detail. And so at this time, I'm actually going to turn it back to Katherine, who's going to review that third bucket of OB3 healthcare provisions focused on eligibility changes with respect to subsidized coverage through the Health Connector. And she'll also review what we know about the potential impacts of OB3 here in Massachusetts. Thank you.
Great. Thank you so much, Jessie. Okay, so let me dive in now to the third and final bucket of cuts that we wanted to cover with you, which relates to the new restrictions on eligibility for subsidized coverage through the connector. But before I dive into these specific provisions, I did just want to note that we're focusing today on marketplace eligibility cuts, but there are also an array of other regulatory and statutory changes that don't necessarily change who is eligible, but that will make it harder for people who are eligible just to enroll in and keep their coverage. We're not diving into those provisions today, but I just wanted to make you aware that there is a whole host of other provisions that are pretty similar to some of the provisions that Jesse walked through on the Medicaid side in terms of just creating new paperwork for folks and new barriers for folks who are eligible to keep them from enrolling. Okay, so focusing now on the provisions that will change who is eligible for subsidized coverage in the marketplace. These changes, like some of the Medicaid eligibility changes, include targeted restrictions in eligibility for subsidized coverage for many legally present immigrants. So the first set of cuts actually went into effect on January 1st of this year, and it applies to lawfully present immigrants with income under 100% of the federal poverty level who do not qualify for mass health because of their immigration status. So this is a group of folks who didn't qualify for mass health because of their immigration status. They were legally present. And so up until now, they qualified for coverage through the Health Connector instead. But under OB3, this group no longer qualifies for premium tax credits and therefore no longer qualifies for the state's Connector Care program, since Connector Care is really built off of the tax credits. I'll say that these folks are still technically eligible to purchase unsubsidized coverage through the connector, but because of their very low incomes, it just makes it very unlikely that that would be a realistic option for them. The next set of cuts goes into effect as of January 1st of 2027, and that will further restrict eligibility for subsidized coverage through the Health Connector for many lawfully present immigrants whose incomes are between 100 and 400% of the federal poverty level. Eligibility for immigrants within that income range will be limited to just a few groups, the biggest of which is lawful permanent residents or green card holders. But the law cuts eligibility for subsidies for a number of groups in this income range that have until now been eligible, including asylees and refugees. So taken together, the state estimates that the cuts to immigrant eligibility for federal subsidies, that these two cuts will result in losses of subsidized coverage for more than 60,000 people in Massachusetts. Finally, we also just wanted to note that while it wasn't a specific provision of OB3, there are another set of cuts that went into effect as of January 1st of 2026 because Congress failed to extend the enhanced premium tax credits. As you might recall, this had been the issue that was central to the 2025 government shutdown. And those enhanced premium tax credits were authorized to deepen the subsidies that had been included in the ACA and also to broaden their availability to people above 400% of the federal poverty level who didn't otherwise have access to affordable health insurance. So the loss of those enhanced tax credits caused two problems in Massachusetts. The first is that people with incomes above 400% of the federal poverty level lost access to subsidies altogether, and therefore they're seeing a steep increase in their health insurance premiums. This affected around 27,000 people in Massachusetts. And then secondly, for people with incomes below 400% of the federal poverty level, the expiration of the enhanced tax credits means that they qualified for a smaller subsidy from the federal government. Fortunately, the Connector Care provided enhanced state subsidies to offset most of the premium increases for this group of people. So that group of people didn't end up experiencing as steep an increase in premiums as might have otherwise occurred. However, it did drive up state costs. Okay, so I'm going to flip to the next slide, which I'll cover very quickly. I just wanted to essentially reiterate something that Jesse said at the beginning, which is that not all of the provisions that we just covered take effect at the same time. The eligibility restrictions in the law started to kick in at the beginning of this year, and the remainder of them really phase in over the next year. But then the financing restrictions that Jesse covered primarily kick in towards the end of 2027 and then phase in over the next 5 years. So we're not really going to see full implementation of this law until 2032. Okay, so now I'm going to switch from talking about the provisions to talking about the impact of the provisions. And this is on the next slide. So again, I'm just going to note the same caveat again, which is that there are still a lot of unknowns about how these healthcare related pieces are going to be implemented, because we're still waiting on federal regulations, and also because we're still waiting to see how the state's going to operationalize some of this. And all of those decisions could affect the magnitude of the impacts that are felt here in Massachusetts. That being said, we know that regardless of the details of those regulations and of the state's implementation strategy, these provisions are expected to have a really significant impact on enrollment and on expenditures for our subsidized coverage programs, and that's going to cause ripple effects throughout the entire healthcare system, and for our entire state budget. So starting with what do we know about the impacts of these coverage and federal funding restrictions for coverage in the state. There have been a lot of estimates that have been put out by a number of different organizations, but what we tend to do is defer to the numbers that the state itself has been putting out. And the state is projecting that about 200,000 people will lose Medicaid coverage over the next decade, and another 100,000 people could lose their coverage through the state's marketplace or the Health Connector. So that's a total of 300,000 people losing their coverage over the next decade. In terms of funding impacts, state officials have estimated that between the OB3 provisions and the expiration of the enhanced premium tax credits, Massachusetts will be losing $3.5 billion federal healthcare revenue per year once the law is fully phased in. So I think it's an understatement to say that this is going to be a major challenge for the state's Medicaid program, which is going to be forced to make really difficult decisions about how to reduce program spending. And generally, state Medicaid programs have just a couple levers to reduce spending in the short term. It's cutting services that they're not required to cover, it's cutting eligibility to populations that they're not required to cover, and it's cutting payment rates to providers. So those are options that state officials will likely be looking to reduce Medicaid spending. But I also think it's worth noting that this also puts the overall Massachusetts budget in a really difficult place, because Mass Health plays such an important role in generating federal revenues that help to support our budget. Federal revenues supply just under a quarter of the funding for the state budget as a whole, and 86% of that federal revenue is generated by the Medicaid program. So while these particular cuts from OB3 are primarily directed to Medicaid and subsidized coverage programs, these cuts are going to have broader financial ramifications for the state budget as a whole. And it merits noting that these cuts aren't happening in a vacuum. As we know, the state is also seeing cuts with respect to the federal investment in SNAP benefits, in education, and other critical programs. Then on the next slide, we wanted to just take a moment and reflect on what these changes from OB3 will mean for our healthcare delivery system more broadly. And as this slide shows, many providers, notably community health centers and hospitals, really rely on Mass Health as a key source of revenue. And the coverage and financing changes under OB3 will put these providers in a challenging financial position because it's reducing their Medicaid revenues because it's cutting back on Medicaid eligibility and on federal Medicaid financing. But it's at the same time, it's also likely that these providers will face an increase in uncompensated care costs from the growing uninsured population. And so these providers may themselves have to make really tough choices about how to manage these difficult financial positions. And these choices might include cutting certain low yield services, closing certain sites, or figuring out how to make do with fewer staff. And those changes would be felt across the entire healthcare ecosystem and among all of us who need healthcare services, not just Mass Health and Connector Care members. I recognize that this is not a very upbeat note on which to conclude our presentation. So just a couple of thoughts before I hand it over to Jessica to talk about what comes next. I do want to just note that next month we will be celebrating the 20th anniversary of state health reform. And state health reform was made possible because people in the state were committed to building a better healthcare system, one that ensured that everyone could access the healthcare that they needed. And in that spirit, people worked across partisan divides, and every major healthcare stakeholder made sacrifices in the spirit of shared responsibility to try to tackle this problem. And I think that the values that inspired that effort and the shared goal of near universal coverage for all persist. And I'm not saying that this is going to be easy, and we're certainly going to experience serious impacts from this law that I wish we could avoid entirely. But I will just say that I feel really lucky to live in a state that is as committed as Massachusetts is to ensuring as much access to care as possible for its residents. And I'm confident that working together, we can find ways to avoid some of the worst possible impacts from these changes. So I'm going to hand it over now to Jessica Collins to talk about what comes next.
Yes, thank you so much, Katherine, Jesse, and Lisa. And Katherine, I appreciate you ending on that history of the power that we have here to work together to change. So with no more delay, let's go over to Ilana Steinhauer, Executive Director of Volunteers in Medicine, Berkshires, who's going to talk to us a little bit about, okay, what's happening and what can we do? So Ilana, if you're still there.
I'm here. Thank you so much. Thank you so much, Blue Cross Blue Shield Foundation and all of your partners. I'm just going to start by saying I'm sitting outside in Quincy, Mass right now at the IFC conference called Charting the Path Forward. And it's the perfect conference to be at for this conversation. It's 70 organizations, many of them grassroots, community-led organizations who are working together to ensure that immigrants in Massachusetts are thriving. And the family of Emmanuel Damas was here, who is the gentleman who passed away in ICE custody from a dental infection. And their words are that we need to come together in crisis. We cannot contract, we must expand. We cannot think about ourselves. We must remember that we are all in this together. And so we are in a crisis, and we have heard the data, and we are seeing the articles, and we're seeing, what everybody is worried from. But there is work that's being done. And I think that, similar to COVID, this is a time when we can really start to think about mitigating harm from the OB3, but also thinking about system change. And so Blue Cross Blue Shield Foundation, who's presenting today, has convened a group from insurance providers to healthcare leaders to community-based organizations to start to think around mitigation as well as system change. The state has, the governor has convened a group. Mass Health has a group. Membership organizations such as the Mass League of Community Health Centers, they are convening to think about what can we do right now and what can we do in the future. So as someone said in the public health forum, At UMass, let's not take popsicle sticks and hold up a broken system. Let's think about how we can start to change it. Next slide. So, what are we going to do today? What are we asking to come out of this organization, out of this convening, out of this educational session? This is really a call to action. And for everyone from the eastern part of the state, we're so glad you're here. We hope you do a similar thing. This is a call to action for our Western Mass area. We know that the community-based organizations that exist in our communities understand the communities that they serve. We know that the system is broken, but we know that we can make shifts if our voices are heard. And so what we're going to ask after this webinar is that people who are interested sign up to be part of a very short working group, 1 or 2 sessions at the most, so that we can ensure that we are able to provide recommendations from our area to these working groups so that our voices are heard, right? We know how to do things like help people prevent losing insurance. We know the power of community health worker networks. We know how we manage during COVID and what it looks like to start in systems, in spaces of trust. We know how to enlist community ambassadors. We know how to ensure access in Western Mass. We have the largest volunteer-based healthcare center in the state. We know how to do education around chronic disease management, how to decrease ED usage, medication management. We know the power of community EMS. We know the investment in healthcare education for not just medical residents, but CNAs, not CNAs, home health aides, nurse practitioners. And we know that the communities, we know how to effectively communicate with the communities that we serve. We know how to use WhatsApp, where are they getting their information? How do we start at the community-based organizations and work out? How do we come to the table, put all of our recommendations together, and then move that out to these big state organizations so that we can't stop this bill from going into effect, but we can mitigate harm. And while we're doing that, really, really start to think about the big system changes that we want to see in the community and do it from the community-led organizations and work outward that way. Thank you. Jessica.
Thank you so much, Ilana. Thanks for sharing that inspiration. So I want to thank all of the speakers. Katherine and Jesse, I noticed that you answered the question as we had said you would in the written responses, but I'm just wondering to City Councilor Zaida Govan's question, which was about, is the state or are the certain state departments putting together information to inform, community-based organizations? Can one of you just kind of respond to that just real quickly? Because I think that's an important call out. What should we be expecting with regard to information?
Yeah, I'm happy to quickly address that, and then Jesse may have additional information to add. So the state is developing a very, what I would say, very robust outreach and engagement campaign to try to ensure that all of the key partners, especially community-based organizations, are sort of prepared with information about what these changes mean and how to help guide and assist individuals in sort of complying or proving their exemptions, etc. A core part of that effort is a substantial, I think, $10 million over 3 years that the state has provided to our partners at Healthcare for All, who are really working to develop a set of core communication materials, talking points, it's Q&A materials, etc., that will then get distributed to key partners across the state to help ensure that we're all sort of working off of the same messages and have consistency in how we're talking about this. They're also going to be providing support directly to community-based organizations and CAC organizations to ensure that they can help work with individuals one-on-one to work them through the application process, etc. So certainly there is a very sort of robust effort being developed right now to ensure that organizations across the state are aware of these changes and are equipped to help people work through them one-on-one. Does that help address that, Jessica and Jesse? Others on the call should jump in and weigh in as well.
I think that covers it. I will just add that there is, for organizations that are working directly with members, there are some upcoming webinars that Mass Health is hosting. And these are actually webinars that are intended for Mass Health members. So not the organizations, they're intended for members. And we can actually put a link in the chat to where the information on these webinars lives on the website in case the organizations on this call would like to share this information more broadly with their member networks. But these webinars will also be an opportunity for Mass Health, again, to educate members directly about what's coming in terms of the federal policy changes and what it will mean for new requirements potentially for members. So I'll drop a link to that information in the chat.
Okay, that very, very helpful response. So appreciate that. We will take the links that are in the chat and we will include them in the package that goes out next week with the recording and the slides and the answers to the questions as we're able to answer them. I also wanted to point out, and thank you, Ilana, for inviting those who are interested in being part of this brainstorming and dreaming of, about recommendations. There is a link for you to sign up, and then we'll follow up with an invitation. I also want to say that Public Health Institute Western Mass will continue to update the 413cares.org website with information regarding resources. So I think please pay attention to that, and we'll be looking to Healthcare for All to provide information, and then we will upload that to 413cares.org. So definitely pay attention to that. I will also say that as data comes out, because again, remember, they're projecting 300,000 people over a decade across Massachusetts. But then Lisa pointed out that a pretty significant amount of those people are here. And so we will try to continue to get data that we can break down so that we really know where and who do we need to be really wrapping our arms around and making sure they get the information they need. So I wanted to call that out as well. And really just want to thank you all so much for being here. Again, Katherine and Jesse, I feel like this is the third time I've heard this presentation, and I just feel like it's digestible. It's confusing. This is a very complex situation, but appreciate you trying to break it down in real simple ways. So thank you again. And we would appreciate, for those of you that were able to join us, thank you so much if you could give us some feedback in the survey. And if we have to bring everyone back in 6 months, if there's new information, we certainly will. And I'm sure Katherine and Jesse would be happy, to join and continue informing. So thank you so much. Heavy information. Let's stick together. Let's work together. And I hope everyone can enjoy this first day of spring and the weekend ahead. Thank you.